My proud privilege to introduce Dr. Yatinder Kharbanda, who is a renowned orthopedician at Apollo Hospital since 1996 and arguably one of the best orthopedicians in the country. And his interest is in TKA and THA, and he's going to talk us through the knee arthritis. Dr. Kharbanda, please, sir.
Thank you, sir. Namaste to all of you. And two things I want to say before I start. This Malviya thing, I get very excited because I've been living in Malviya since 1967. And for me, at that time, this was the end of world because there was hardly anything beyond Panchsheel, and so that reminds me, I shifted from Malviya to Panchsheel enclave only in 5-6 years ago, but I still am in this area. I'll talk about, that's my background. I'm actually not from, my medical education has been in Bombay throughout, and then I was in England for about 6 years, and then since 96 I've been at Apollo. And I practice, of course, every orthopedic surgeon starts with everything, but now I practice mainly hip and knee joint replacement surgery. I have a very special interest in teaching, and I believe that to teach, I was not taught knee replacement or hip replacement in even a place like Mumbai, which used to be quite frontier of the medical education, because there was hardly anything being taught in the medical colleges that time. So I started my ABC of joint replacement in England, but I think now we have so many of us who can teach our junior Indian colleagues, and I believe that cadaver workshops are the best. So I hold cadaver workshops in AIIMS, Delhi, Bangalore, and we also set one cadaveric workshop in Himalayan Institute of Medical Science there. So talking about this, I mean, this is how you see patients today. People walking, a lot of them walking like this, and they are basically suffering from knee arthritis. Now this is a degenerative arthritis, but if you see people like this, they can hardly walk. And if you see her hands, it is rheumatoid arthritis. So these are two types of arthritis that we see, and these are people who are younger. They come to us at age of 40 and 45. There are other reasons also, but the issue today, what I'm talking about, is arthritis, which most of us will have, and today also 40% of people above 70 years of age suffer from arthritis. So I'm going to divide my talk into non-operative because that's going to be useful for you, because 99% of the patients don't need surgery, and they need medical treatment, they need counseling. I'll talk a bit about surgical treatment, what's being done, and also the advances. So why is this problem? It's quite a simple thing, but we always make it more complex and difficult. The most common reason for this problem is overweight and lack of exercise. These are two major things, and if these two can be controlled, you will have you'll have good knees. Overactivities, like in sportsmen, they have this problem, poor nutrition and injuries. But the most important thing is overweight and lack of exercise. Now I see these two problems, hereditary and malalignment of the knees. Hereditary, what we are born with, nobody can do anything about it. I mean, some people are born with weak cartilage, some people are born with good cartilage, some people have good muscle mass, some people have less muscle mass. Now that you cannot change much. Malalignment of the knees, what you are born with when you are growing. So a lot of people will have varus of the knees, you will see bow legs, and some people will have knock knees, valgus of the knees. Now these malalignment is the problem, which we can correct if caught earlier. So as I said, most common diseases are osteoarthritis, that is age related or activity related. Second is rheumatoid. These are two things that we treat. But arthritis can happen due to anything like injuries, fractures, infection, most commonly tuberculosis, and certain metabolic diseases. Who comes to you? Which patients come to you and with what complaints? The most common complaint is pain, and I will treat them only for pain, even if I have to ultimately operate. I will not, operate unless they have very severe pain. If they come to me that they have less movements, I will not operate. If they come to me that their legs are not looking good, I will not operate. So pain is the most important symptom, followed by stiffness and swelling and night pains. You must have heard a lot of patients tell us, "Unka to theek nahi hua, they did not do well, they did not do well." So as as we always say that selection of our patient is the most important thing, and the surgeon, a good surgeon is the one when he knows which patient not to operate. So always correlate arthritis clinical symptoms with radiological symptoms. Now, if a patient comes to me with a pain in the knee and the knees look like this, where there is good joint space, I would search for other causes. It could be bursitis, it could be synovitis, it could be spinal problem, it could be muscle weakness, it could be cartilage weakness, it could be so many things. If you operate this patient, they would not be satisfied. But if you do this, operate this patient where there is a joint space narrowing along with clinical symptoms, they are the ones who need treatment. So treatment, the conservative treatment which most of the patient need is multidisciplinary, and these are things that I am going to talk about. So I will go quite fast on this thing. And these guidelines, the authoritative guidelines, we have two societies who give most of the advice regarding non-operative treatment. As you can see here, weight loss is the most important thing. So if a person loses, so if a person is 70 kilos and loses 7 kg, they would benefit by 28%. So that's the importance of overweight. And the next important thing is the exercise, the physical therapy, which is the most commonly prescribed treatment of osteoarthritis. The most important thing is strength training and not exercise like walking. I mean, a lot of people come to me and they say that my cardiologist or my other people have said you walk. But then walking, if the patient has, knee problem, they can't walk. So that does not mean that you don't do other exercise. Yoga is a good exercise, muscle strengthening is a good exercise, cycling is a good exercise, swimming is a good exercise. So they have to do physical exercise. And the other forms of physiotherapy like TENS and ultrasound and other things like laser and these kind of things, these are very short term, but most important is the strength training. And that is the highest quality of evidence that we have, that strength training improves the pain in arthritis patients. And when you tell them about exercise, tell them simple exercise which they can do at home, they can do while traveling, they can do at work. And not tell them difficult things with therabands and with weights. So what happens is when they feel like doing exercise, they are looking for therabands or weights and they don't do. And when there are therabands there, they don't feel like doing exercise. So tell them something. So I give to all my patients a video which I have prepared, and I tell them to do the exercises the way that I show them in the video. The braces. Now braces help only to certain extent. They don't help because patients don't feel like wearing brace all the time. So it's only for short duration and for certain times only. Now this is the thing which a lot of us depend upon and which a lot of patients want. They don't want us to tell them that do exercise, lose weight, use braces, do hot and cold and these kind of things. But these are not good, these are obviously, you would know, you would agree, these are not good things. So I'll go one by one. Oral anti-inflammatory, besides paracetamol and maybe COX-2 inhibitors, don't give them anything else. Don't put them in the habit of taking drugs. These can be taken for short duration for a week or 10 days. The second thing that we are giving them most of the time is glucosamine. Now for us, in scientific literature, we do not find glucosamine tablets, that is, all these Rejoint and Colaflex. These are not helpful. These are only, for us, they are actually like toffees or candies. We don't have any conclusive research, but all the research coming or all the papers coming from the pharmaceutical company, obviously they are biased. But then, because it does not cause harm, you can give them the other advice and put them on these tablets for some time. Intra-articular steroids, these are good things, but again, they are only useful for short duration. Again, you have to tell them that, these are only to get rid of the synovitis and the inflammation, and not your other things has to be done. And these are important when it's a chronic synovitis or patients who have chronic renal disease, liver disease. So I prefer this, and you can avoid NSAIDs for these patients. Viscosupplementation again is a very popular thing. Again, it's a very costly thing, and it's the only people who benefit are companies. I don't believe in this because most of the time arthritis is not only biological problem, it's a mechanical problem also. PRPs are plasma, platelet-rich plasmas, which again work for very short duration. They work for tendinitis, but for arthritis, again, because it's a mechanical problem, they don't work very well. But our guidelines, they do tell us to give them because they're harmless. Stem cell therapy is too costly, and it's not really proven that gives rise to cartilage regeneration. Radiofrequency ablation, some of the anesthetists and orthopedic surgeons who are trained in ultrasound guided injection, they do give this radiofrequency ablation of the nerves, which can benefit up to 2 years, and it can be repeated. It's a mechanical thing, so it's not a harmful thing at all. So to summarize, non-operative treatment, non-pharmacological treatment is the most important. That modify your lifestyle, weight loss, exercises. Most important is the muscle strengthening exercises. Physical therapy can help for a week, 2 weeks, and bracing and these things are again very temporary. In pharmacological options, you have steroids, which I prefer if the person has problems, and most of them have some other medical problems. Non-steroidal like paracetamol or at the most COX-2 inhibitors only for short duration. So ultimately, most important is weight reduction, regular exercises, modification of lifestyles and activities, occasional non-steroidals, and supplementation of calcium, vitamin D, glucosamine. One has to refer a patient who does not respond to non-operative, or those who have complete loss of joint space, deformities, extreme pains. And we have 3 surgical options. One is arthroscopy, that is, just doing debridements and taking out loose bodies. Second is correction of deformity. I'll show you what I mean by that, and last is knee replacement. Now if I catch a patient like this is a lady who was 39 years old, and she already is complaining of pain. She already has, you can see that there is a malalignment. This is what I meant, that if you have a malalignment right from beginning, you will end up with early age arthritis. You can't really stop it unless you have, like, it's like a car ka tire. If it is crooked, you will go for alignment. No? Otherwise the car tire will wear off whatever quality you put. So this patient needed some correction so that the arthritis doesn't progress fast. So we have various ways of correcting the deformity, but there is an osteotomy, or we basically cut the bone below the knee and correct it. So this is one way of doing it, which is an external fixator. and you can see that the bow legs have become normal alignment. This is not knock knees, but this is a normal alignment. And this lady actually needed knee replacement after 12 years. One side I did after 12 years, and the second side I did after 20 years. So I could actually give her almost 12 to 20 years of her own natural knees. Now if you catch these patients at this early age, now this is only a 35-year-old person, and he's already got arthritis and deformity. But obviously 35 you would not do a knee replacement. So here again we did, you can see these marks here where we did external fixator, we corrected, there is no implant inside, and he's fit and fine and walking, and hopefully will not develop arthritis till quite late. This lady, she is only 22 or 23, married, and she came to us like this. Now if I leave her like this, in another 5 years she would not be able to walk properly. She would develop bad arthritis. So this is how her legs were. And you can see that the joint space is still there, but soon this joint space here, because more pressure is coming, the kneecap is already dislocated. So if we correct this at early age, or whatever age they come, we can prevent doing a surgery like a knee replacement surgery for some time. So we did this, we corrected her femur bone, we corrected her tibia gradually with a fixator like this. And with this they are able to walk, they are able to do all their activities. They are able to drive also, they are able to ride the motorbike, whatever they want to do. They can do everything. While the bone is getting corrected and it is getting healed. And this is what she was after 6 months of treatment. So now hopefully she is 23, 24 and would probably go on for quite a long time before she develops arthritis, if it has caused some damage. But then they have got so much of regeneration that they don't develop arthritis very early. So this is what I meant by correcting the deformity and not doing any knee replacement surgery. I mean, obviously these patients would not benefit from non-operative treatment or even and don't need, obviously should not need a knee replacement. So knee replacement is done when the joint space is completely gone and the patient is elderly. Today we are getting patients even up to 50. I mean, previously we used to get more than 65, 70 for this surgery. But today we are getting, because of the bad lifestyle and obesity and not doing exercise. But I don't touch the patients who are not willing or who are too old, elderly, multiple medical problems, or who have some kind of infection anywhere in the body. Basically what we do is just put this implant between the femur and the tibia. So this is all what we do. And the correct alignment. This is what is done for a knee replacement. Most of the things remain the same, the patella, the quadriceps muscle, the ligaments, the bones. So a lot of patients who tell us that I did not get the same result whereas this person got the same result, it's basically because they have other problems like obesity, they may have poor muscle mass, they may have spinal problems, but they would surely get a lot of benefit if their non-operative treatment has not worked and the knee is completely gone. This is one example here. A gentleman, I mean, I would wonder how he would be walking with these knees. But he came to us in such a bad condition where there is hardly any, I mean, it's not looking like a knee at all. But we are able to do, I mean, this is the surgery which has probably changed the quality of, I mean, it's a turning point in medicine. I think there are two surgeries which have changed our medicine. First is cataract surgery, where the person is able to see. The second is joint replacement, when they are able to walk very well. So this may need a bit of more than a knee replacement surgery, but they are able to get the legs back and they are able to walk very well. This is the lock knees, which again the procedure is the same. ultimately the objective is to get the alignment right and not to make the bones grind against each other. A lot of people have myths that they may be bedridden or this and that, but we have to clear that they should be walking the next day. Okay. They are usually walking the next day, they get full recovery in 3 to 6 months. And they really have good function. Like a lot of people who are thin, they are able to sit like this. So I would not take further this thing, but because I have been given a signal that I am, going over time. But computer-assisted surgery, you may have heard, it is one surgery which has actually changed quite a lot of in knee replacements and the hip replacements. They are able to sit well, and now it's a robotic surgery. But all these things are only reserved for some patients, not for all patients. I'll show you last 4 slides. This is a rheumatoid who is walking like this, and after his knees have been replaced, he's able to walk. He still has a hip to taken care of. But they have marked change of quality in their life. This lady who has been suffering, she's only 60 years old, but suffering from some knee problem since the age of 5 years. And this was at 3 weeks, she was able to walk pretty well and pain-free. So in summary, arthritis, majority need non-operative treatment as I told you earlier. Regular exercises and appropriate body weight is the crux. Good nutrition, of course, is important. Malalignment of the legs should be corrected first at an early age. They should be offered to the patient. Half knee replacement or full knee replacement only when the arthritis is advanced, and 95% patients would find this operation successful. There are many advancements which are basically to improve the quality of life. Thank you for your attention.
Dr. Kharbanda, and please come.
Please come to the dais on the hot seats. Friends, you must acknowledge we had wonderful 2 talks and they were poles apart but yet united. मुझे याद आ गया, मैंने एक मूवी देखी थी हिंदुस्तान की कसम, जब उसमें को don't take it that there is no benefit. Now next to Dr. Tulsi officially.
So we had a great first session, and now we put Dr. Kharbanda sir under lens. We had a wonderful talk by him. He showed beautiful cases. His emphasis was delay the surgery as far as possible, managed by non-pharmacological means. If your patient is overweight, obese, nothing will help him unless he loses weight. He would never encourage his patient to undergo the knife unless and until he has lost weight, and great benefit by losing weight. Even if he loses only 10% of his existing body weight, the benefits are to the tune of 28%. So delay the surgery as far as possible. But we know that arthritis does not come in one contour. It comes in different contours, different shapes, different sizes, different hues. And third said, therefore, the results of the surgery are so different. Over to the next talk, and with Dr. Tulsi's permission, I would ask the first question. Sir, you showed some good cases of rheumatoid arthritis, and they start early. And we know that any surgery that you do would probably require a revision surgery. So, if a child has rheumatoid arthritis, has knee involvement, hip involvement at the age of 5 years, a case that you showed actually, the diagnosis was not there. Sir, I would like to ask you, how long can you keep this child on disease-modifying agents? And what is the threshold where you say, okay, no more non-pharmacological treatment, I need to operate this patient now?
Some of the patients who are early rheumatoids or seronegative spondyloarthropathies like HLA-B27, ankylosing spondylitis or psoriasis, we sometimes have to operate as early as 18 to 20 years of age. The only time I'll operate if the joint is non-sulfate. And they would be on treatment, medical treatment for as long as their disease is active. And while the disease is active also, if for some reason their joints are, they become bad, and even, some of my colleagues in elsewhere in India, they have even operated children of 15 years old and 16 years old. Because if there is a joint which is destroyed and they want a good functional movements today, at present time, then the only answer is joint replacement. Some people we would avoid doing this, though a lot of patients would not agree, even adolescents, of fusion of the hip or fusion of the knee, which used to be done in the past when the joint replacement was not done. But that's a thing we would offer them, saying that this would last forever. But then they have other effects, like if you fuse the hip, they will have some problems in the spine ultimately. So most of them would accept a good joint which can work for 20 to 25 years. And today the revisions can be done, and they can be done at that stage also.
Sir, I was just wondering, if you do a knee or a hip in a rheumatoid patient, what happens to the implanting joint while the rheumatoid process? Does the natural history of rheumatoid arthritis change?
No.
So what happens to these joints?
In the natural way, the joints, the cartilage gets destroyed by the synovium, the hypertrophic synovium, which produces toxins and all those kinds of things. This does not happen to a metal or a plastic.
So they are safe?
So they are safe, absolutely, though they may have synovitis, they may have pain due to synovitis, they may have muscle rheumatism and muscle pain, muscle weakness, they may have some results of any joint replacement in a rheumatoid is not as great as a degenerative joint, because there the disease is only in the joint, and you change the joint, and as long as they take care of their muscles, their bones, the osteoporosis part and all those things, they are very well. Whereas here it also depends upon how best the rheumatoid activity can be controlled. So,
Systemic disease.
Yeah, it's a systemic disease.
Sir, you mentioned about osteoarthritis, and you gave a lot of importance and emphasis on non-pharmacological treatment, weight loss, COX-2 inhibitors, paracetamol, etc. Exercise and weight loss remain the primary focus. And you also mentioned something which I picked up. You said, my preferred treatment is that I would like to give some corticosteroid injections. Sir, how many corticosteroid injections do you give? And at what point in the timeline you say, okay, enough of corticosteroid injections, I would like to move on with knee replacement?
So why I give corticosteroids, I'll tell you. Obviously, I would not give to a person who has not got synovitis. The person who has got synovitis, they need to walk, they need to keep doing activities, they can't sit for 3-4 weeks without putting weight on it. They have to do daily acts of living. So I give them steroid, but telling them very clearly that this is purely to reduce your synovitis and pain and swelling. The primary problem I'm not doing anything. That you have to do, and that is by whatever way. Reduction of weight, reduction of doing good exercise, not doing activities like squatting and jumping and running and stairs and these kind of things. So that I tell them, and if they come back to me again, then I would not encourage them to have every 2-3 months injection, and generally I don't have to. unless there is somebody who's rheumatoid, who has systemic disease, who keeps getting problems.
One injection of steroid, how many months of relief?
It can last forever if they take care of the primary problem. And that is if they take care of this thing. So I don't have to really give. I've never given more than, some people they come to me after 6 months, some people after a year or so. But I've never given them more than 2 or 3. If I have to give more than 2 or 3, that means I'm not, or he or she is not taking care of the primary problem.
Sir, my last question. If a patient has concomitant OA of hip and knees, which one do you first and why?
Hip is always done first. They can actually, if their hip is painful, they cannot propagate themselves. If both the hips are involved, then they can't, they have to shuffle they have to shuffle their way to propagate. Knee, they can carry on. So hip is always done first and then the knee.
It's a great talk and great answering. I would like to talk to Jaya. Please.
Dr. Kharbanda, you said RFA is one of the options. So what are you ablating here?
There are saphenous nerves around the knee, and I don't do it, but my anesthetic colleagues, they pick up with the ultrasound the nerves, the sensory nerves which are above the knee and below the knee, and once you ablate them, they can work for 6 months to 2 years. I mean, they generally, a person gets pain-free, relatively pain-free.
Only for 6 months. So it will be done under local anesthesia?
It is just done, yeah, I mean, you give local to the skin only, and then the same needle, RFA needle is put, and you localize the nerve with the ultrasound. No specific precautions. It's the same precaution that you do give it for the any knee replacement, and that is that they don't sit cross legs, they don't squat, they don't play sports like like where there's a lot of twisting or where there's a lot of jumping. These are the activities that they have to restrict. Otherwise, they can do all the functions.
Dr. Kharbanda sir, you mentioned about PRP and stem cell. We are very privileged to have Dr. Ashish Verma, who is an anesthesiologist by profession, but deeply into this PRP and stem cell thing for a number of years. He would like to have a question to you.
Yeah, so Dr. Kharbanda, if you would remember 90, as you said, you are from Malviya Nagar. We have worked together long time back in 93, 94. Vashish Clinic and Sunil Nursing Home, I operated with you. I was there. It's been so long now. So I graduated into stem cells. So my question is, like you said, not much data is there for this thing. So I am treating basically patients for rheumatoid arthritis, where other joints are involved, except the knee, because patients who have knee problem, they come to me at a very late stage. And stage 3 and 4 is very difficult, where surgical intervention is a must, and that is not when I would like to intervene with stem cell. But stage 1 and 2, even knee, I have treated patients and they have not gone beyond that stage. So what's your experience with stem cell, as you said?
So stem cells are not done, but I do PRPs. But as I told you, there are two problems in knees or hips, not the other joints, and that is a mechanical problem. So if there is a patient with the varus knees, whatever you do, they will have problems. And we have seen that once we correct the deformity, so medial joint in varus knees, the medial joint space gets narrowed and the wear and tear starts happening much more there. But when we change the mechanical axis and we put the line of axis more on the lateral side, automatically we see joint space narrowing, becoming broader, and the cartilage coming up. Now in those people, it has been seen that either we put this visco supplementation or PRPs or even stem cells, they benefit slightly more. But you have to correct the mechanical axis. If you don't do that, then but for wrists, for shoulders, that may not be the problem there, the mechanical access.
So the idea is long dilatation is a physiological problem where there is some infection and you are not able to reach and you are not able to correct that. Stem cells has the scope of reaching into those areas and correcting that factor which is causing the arthritis. But once it is caused and a mechanical problem is taking place, then first, then surgery.
Then you know that's why reports are there where you have corrected the mechanical access and given this stem cell or visco supplementation or PRP, they benefit more than just correction of mechanical access.
Right, sir. Absolutely. Thank you, sir.
Dr. Amitabh, neurosurgeon at PSRI has a question.
Sir, that was a nice talk. What I would like to know is you said that lifestyle modifications, especially for obese patients. So first of all, the problem with obese patients is if they have joint problem, they have a spine problem, they won't be able to walk. And that's the biggest problem with them. So unfortunately, we have to look for operative intervention to make them walk so that they are able to do those things.
So first, my first question is, who has lost weight with this walking?
So I'll tell you.
So
before that, I will just tell you my experience. Before that, I just operated last 15 years back, 200 kgs patient of spine. And he was not even able to sit for 30 seconds.
It was in the paper, Times of India.
So let me tell you, sir, that unfortunately, he had to undergo bariatric surgery or something. But he said, first let me at least stand or sit. And he was not even able to lie properly. So my thing is that if I don't give him that benefit, then where do I ask him to stand, sit or and do anything to lose weight?
yeah, so in your case, it was slightly different from a knee or a hip arthritis, back arthritis, because knee arthritis, even if it is the last stage where person cannot even stand, they can still sit. And they don't have pain at all in sitting. Whereas in your case, if the nerves are, getting compressed, then you have to, decompress that and you have to give pain relief first. So that thing is slightly different. But for people who are obese, why I don't operate unless, of course, they don't lose weight at all. There are surgeries where we do in obese patients also. But weight loss is not done by walking. And weight loss is only done by dieting. And the simple example is that if you jog for at a speed of 8 to 10 kilometers an hour, jog for 5 kilometers, which you can do in 40 minutes, you lose only 400 calories.
So I will come to that again. I will come to that again.
560 calories.
So my advice to my patients is, spine patients I am talking, who can't walk, who can't do. I tell them to do cycling, and that is stationary cycling. So please understand that is not the only way to lose weight by jogging. You can even do a stationary cycling and still lose weight. So a patient who has a knee problem can't do a stationary cycling. So we need to understand that there are certain ways how to modify the activity. Both ways. So I think knee replacement is a good choice if the patient is having bad knees, and also he can lose weight probably by doing certain different exercises according to his particular morbidity.
See, telling a patient to do some exercises and doing these kind of activities is basically to get them into mode of doing this thing. But I can tell you, 99.9% people don't lose weight even after I've done after you have done your knee surgery and after done a knee surgery.
10:45 friends, I gave Dr. Tulsi sir 5 minutes to wind this up.
Finally, Dr. Juan, are you annoyed with me?
No.
You have given me just 5 minutes?
Yeah.
Okay, let's go ahead, friends. We must confess that was a wonderful talk by Dr. Kharbanda. So this is the first time we are hosting Dr. Kharbanda.
Yes.
He's such a renowned orthopedician in the city of Delhi.
Yeah.
We must have you more often, sir. And
We will have one more after 2 months.
And so, friends, he said all arthritis need not undergo surgery. most of the orthopedicians would say probably they would need surgery, but Dr. Kharbanda says no, they don't need. Only the end stage or the stage 4 of osteoarthritis is the only option, or for the TKA, or when the joint space is completely gone. So, Dr. Kharbanda, I'd like to ask you, Dr. Ashish is there. So, intra-articular injections of mesenchymal stem cells, and not to forget hyaluronic acid, the corticosteroid, the PRP, quality of evidence, sufficient quality of evidence is not available. So, I beg to differ here. See, probably they really don't help your words. The evidence, the quality of evidence is not enough to suggest that these really do help. Go ahead, sir.
That's right. It's, as I said, that you have to consider both the things. I would probably give visco supplementation or a PRP where there is no major malalignment and there is no major loss of joint space, indicating that it is basically a weak cartilage or weak muscle.
Do they really help? Because there isn't enough evidence to suggest that these things work.
They work, but when the alignment is okay, that's the only. And the other things are also in favor of them. That means they do lose it. So there are no trials, there are no papers which have actually done studies where they have given one patient, segment of patient only viscose supplementation, the other one weight loss program and exercise, and the other one both. So there are no such trials and papers suggesting that one works on, because when we give the advice to a patient about this thing, we tell them everything, and how much they are doing what. That depends, and that actually...
Point very well taken, sir. So can we conclude, friends? If you have any other question? I'd like to extend the mic to Dr. Chauhan.
I would request Dr. Tulsi to summarize the CME for us, the second CME.
So friends, as already summarized, you would say probably, you see, all arthritis patients don't need surgery. See, as Dr. Kharbanda said, majority of this, they won't need. Only in stage 4 or end stage probably would need surgery, and surgery means probably the TKA. Having said that, Dr. Kharbanda, probably in the next talk, you probably talk us through the TKA, the latest innovations in TKA, and referring to the robotic TKAs and the 3D modulation as well. We'll have Dr. Chauhan, let's see you.
Sure, sir, sure. As I always say, friends, I think we had two wonderful talks. And in the end,